Oh, goodness, I think I'm finally ready. Okay, any questions before we get started? At least on a cold, dreary day, it's nice to be in a warm classroom. I hope you got something out of Dory Weaver coming, and especially the two students, because they were really nervous. Jamia was nervous, she was the one on the left, and she ended up talking really well and coming across very well, but they were in your shoes last year, I believe, okay? So they're juniors. So last year, they were sophomores taking physiology and whatever else they needed, so they're now in it. And I'm really glad they gave some, they kept it real. What is it? Jamia said, she said that, I can't remember her comment, but everyone laughed. But she was very encouraging you as well, which I think is important, okay? Because it is doable, it's totally doable. Not that it's not overwhelming, but it's doable. Okay, so believe it or not, we're gonna finish up on this chapter 4, part 1, which is the neurotransmitters, but doesn't mean we're done with them. Because I'm going to keep coming back to them, keep coming back to them, keep coming back to them, because they're that important. Today, as we get through the monoamine neurotransmitters, dopamine, serotonin, and then importantly, epinephrine. And I'm going to talk about how epinephrine plays a role in your fight, flight, or sympathetic response to danger when your life's on the line. Okay, so it's going to be polar opposites of what acetylcholine does to your body under parasympathetic arrest and digest. And I'm going to teach you 3 receptors for that. There's a lot more than that, but I'm just going to teach you the 3 basic ones and teach it to you in a way that I hope that it sticks in your brain forever. Okay. I got an email over the weekend. No, it was a Facebook post. Someone just got their finished their NCLEX. That means they got their license to practice. And I said, congratulations, Dr. Thank you so much for teaching us all that in physiology. It really helped. So it's all the time. So it's really true. I'm teaching you just what you need. And I know that you need it, and I get the feedback that reinforces it. So try and grab a hold of this stuff, and don't dump the hard drive when you leave the class, because you're going to need it again and again. So we had talked about serotonin, and we talked about what it does, and that there's only a few receptors in your brain. So if it's low in your brain, it can lead to all kinds of things like depression, anxiety, OCD, things like that. And we talked about 2 treatments, SSRIs and then MAO-I class A's. And I explained that there's many different treatments for a condition because not everyone is going to respond to one treatment the same way. And so they formulated many treatments. And I have this is showing you that when serotonin is released from a neuron, so let's say in the brain, and this is another neuron in the brain, that the serotonin, in order to increase the serotonin in that synapse, you can either block its reuptake. And so that's what SSRIs do. And so without being taken up by the neuron that secreted it, it leaves more serotonin in the synapse. And that's what alleviates the symptoms of a serotonin deficiency. And you can also use monoamine oxidase inhibitor, MAO-I, class A. And I want you to tie in your brain, the A could be for anxiety, because it could increase epinephrine. But we're not talking about epinephrine here. The A also can stand for appetite, because serotonin does play a role in appetite and digestion. So think about that. So both of those work to increase serotonin. The MAO-IA prevents its enzymatic breakdown. So 2 ways of approaching problems. And you're going to learn so many more drugs than that. Let's talk about dopamine. But dopamine is pretty important too. Dopamine plays a role in fine muscle control, motor control, and addiction. Problems with those you're going to see regularly as a nurse. So dopamine, and we'll get to this in the next chapter when we go over the central nervous system. It's produced by the midbrain, which is part of your brainstem, and I hope you remember where that is from anatomy. But in the midbrain, it has neurons that are called the substantia nigra, and they produce the bulk of the dopamine in the brain. It's not the only place it's produced, but it's the main place it's produced. So 2 functions of dopamine, and there's more than this, but I'm just going to give you these 2. Fine motor control. So dopamine plays a role in that. How do we know? People who have Parkinson, they found after brain scans, MRIs, CT scans, but probably MRIs, they found an area in the brain that where the neuron clusters should be pigmented, and in normal people they are, But in Parkinson's patients, this particular area of the midbrain is bleached out. And then they started realizing, oh, but this part of the brain produces dopamine, but those neurons seem to be dead. Oh, that might be, and dopamine might play a role in Parkinson's. So the fine motor control function of dopamine is called the nigrostantial dopamine system because it's produced by the substantia nigra neurons in the midbrain. So low dopamine leads to neuromuscular problems. You get the shaking as you try and grab something at the end of the movement arc. You get all these, I don't need to do that. You get all these shakes, all right? And I don't know in your generation of public figures that have Parkinson's, but back in the day, Michael J. Fox was definitely a public face to it because he's in so many movies. And then he basically dropped out of movie career because he can't get his tremors under control. So that's hard to do. So Parkinson's, there's a clinical app online, which we will look at, and it's a long read. I won't go all of it. Not this, but here, all right? Most of the symptoms of Parkinson's disease, all right, degeneration of dopaminergic, basically fancy word for saying neurons that produce dopamine, in the substantia nigra. They also point to another one, but I'm just gonna have you focus on this one because it's the main producer of dopamine. The causes of Parkinson's are incompletely understood, and that is true. Environmental agents, toxins, things like that. It rarely runs in family, and I'm like, whew, because my grandfather had it. And I was worried for a long time, and I realized it doesn't tend to run in family. Okay. Parkinson's disease is associated with rigidity, resting tremor, okay? Imagine how hard it is trying to relax or sleep when your body's tremoring, and difficulty initiating voluntary movements. That can really disrupt your life, all right? My granddad was practically confined to a bed because he couldn't control his body enough without being on a walker with people around him on either side to touch him because he couldn't control his muscles. Parkinson's disease is treated with L-Dopa, the precursor of dopamine in its chemical pathway, or dopamine agonist. What is it? It's not on here, so I can ask. What's the drug that inhibits the enzyme breakdown of dopamine? What is that drug called? Monoamine oxidase inhibitor, which class? A or B? B, dope B, all right? Dope is for dopamine. And B is if you're drumming or something, you're using muscle coordination. So MAO-I, class B, dope B, all right? MAO-I, class A is for anxiety and appetite, for epinephrine and serotonin would be built up, but MAO-I class B is for dope B, it's for increasing dopamine. So they don't show it here, but you can treat with L-Dopa. What happens if your patient doesn't respond to that? They should, all right? But you can supplement their treatment with an MAO-I class B to increase dopamine by preventing its enzymatic breakdown. This is why I cover these things. And there's all kinds of other treatments they're looking into, so I'll let you read that. But, okay, we'll just close this one. Okay. Close that. There we go. Okay, so that's motor control problems from lack of dopamine, and there's treatment. I'll put insufficient dopamine. TX, come on, pen. Change color. Just to reinforce what we were learning. Treatment from the reading is L-Dopa, which is chemical precursor dopamine, or MAO-I B. Right? That's a couple treatments. There's many, many more. Now, too much dopamine, also a problem. And they're just finding this out. Schizophrenia. So schizophrenia, lots of things going on with schizophrenia. These people tend to hallucinate. They tend to see or hear things that aren't there. The voices are talking to them. They perceive it as true, but there's no external way that's true. So too little, too much, a problem with neurotransmitters. Now, I don't have any drugs, but what do you think you could treat someone with schizophrenia? Would it be a dopamine agonist or a dopamine blocker? Blocker, because the problem is too much dopamine. This you treat with an agonist on dopamine. This you treat with a dopamine blocker. All right. So even though you don't know the drugs, hell, I'd have to look it up too. But I know the class of drugs you need, they have to be a blocker. Okay, that's one thing, neuromuscular function. The other is addiction. You are gonna see people coming to doctors' offices trying to get their fix. And it might not be their fault. They could have had take me for example. I had surgery and they prescribed me an opioid-based painkiller. I never took it because I'm scared to death of those things because they can lead to addiction, okay? It treats the pain, but then you get, I'll talk about the role of dopamine in addiction, but when you take these things and they cause a relief of pain, which is close to pleasurable feeling to have relief. And what happens is you get a dopamine surge in the brain when you take those drugs. Or cocaine, methamphetamine, even for some people eating, drinking, smoking, anything that can cause a lot of pleasure, you get a surge of dopamine in your brain, a dopamine wave, okay? And that reinforces the pleasurable behavior. It felt good, I want to do it again. So when you talk about mental or psychological addiction, which is different from physical addiction, that psychological addiction is a dopamine surge, and it's the emotional reward system. You do something that feels good, you get a surge of dopamine in the brain, and it's called the mesolimbic dopamine system. The limbic system is about emotions, memory, etc. But it is part of the brain that receives that dopamine surge. You might have learned the limbic system in anatomy, I don't know. But if you have a patient and you recognize as a nurse because you're on point and you're spending time with them, you're taking a patient history, and they're saying, well, Mr. Smith, I noticed your bone surgery was 2 months ago. You should be healed at this point with physical therapy. I don't see why you need a refill of your oxycodone or whatever opioid-based pain medication, right? Shouldn't need that anymore. Oh, but it hurts, it hurts. You got to start thinking, are they addicted? All right, that's not for you as a nurse to say, but it's something for you to report to the physician assistant, or nurse practitioner that's overseeing the case, okay? That's an important thing. You don't want to miss these because they can kill people. So anyway, addiction, dopamine release, the big thing. Now, if you have someone who has an addiction, a psychological addiction to whatever, you think you're going to treat them with a dopamine agonist or a dopamine blocker? Because you want to block that chemical reinforcement of the addiction pathway. You want to break it. And then they get other treatments to support them and everything like that. But you want to not have that dopamine surge. You don't want them to get the cookie from doing the drug, okay? You want to block that pathway. So here's the image here. So you have a neuron, and then you have a neuron that's receiving it, got dopamine receptors, and this is how drugs can increase dopamine. So this is while eating food, and food tastes good, right? You get a little bit of a dopamine release. Now, people who have an addiction to food might have more of a reaction like this. So people who have addictive personalities, whatever it is that gets that pleasurable feeling, this is the difference in dopamine release versus a normal brain pathway, okay? And it's that dopamine surge that causes the psychological addiction that makes it really hard to stop, okay? They say quitting smoking is harder to do than quitting, not cocaine, not methamphetamine, heroin. I've heard that. Now, not having been a heroin addict ever in my life, I don't know if that's true, okay? Now, I also don't smoke, but I know it's a very hard addiction to stop because of that dopamine surge. Okay, moving on, drugs and dopamine release. Like I was saying, if it produces pleasurable feelings, you'll probably get a dopamine wave, and that reinforces you want to do it again and makes it very hard to stop. So here's what, say, cocaine and methamphetamines and other drugs can do. They can affect all these monoamine neurotransmitters. They can be an agonist, all right? Cocaine is an agonist to dopamine. There you go, your psychological addiction, serotonin. And in the brain, norepinephrine, okay? In your body, that would include epinephrine, because epinephrine is a monoamine neurotransmitter. So if you have too much serotonin, it can actually cause hallucinations, all right? I haven't put it on here, but it's called a serotonin cascade, which can lead to seizures. Too much serotonin can lead to hallucinations and seizures. You also get with too much dopamine, the muscle tremors, okay? Because it's controlling muscle tone and stuff, and the addiction, and that's the tough one right there. It's hard to get people to stop. And then, of course, too much norepinephrine in your brain is jacked up on full fight flight. Pupils might be dilated. All your brain is on high alert, all right? In your body, too much epinephrine, we'll talk about that, causes you to be in full fight flight mode. That's gonna feel awful. Your heart rate's gonna skyrocket. Your bronchioles are gonna open up. It's not bad, but the blood pressure goes through the roof, and there's all kinds of other things that can happen. So, and there's an online app that you can look at it, but I think I've described it enough. I don't need to go to it. You can look at it if you'd like. But yeah. Now, so we talked about serotonin, talked about some drugs to treat low serotonin, talked about dopamine, talked about drugs to increase dopamine, didn't really talk about drugs to block dopamine, but you get the point. Now, epinephrine and acetylcholine are opposite ends of the same coin. Acetylcholine is going to rule your body under rest and digest. All right, let's recap before we go on to this. If rest and digest is parasympathetic nervous system, it controls your body function under rest and digest. You do things that you have no voluntary control of. So under rest and digest, acetylcholine binding to muscarinic cholinergic receptors. They're called cholinergic, and they're called acetylcholine. They're muscarinic because it's autonomic body function that you must do if you have no control over it. So all parasympathetic functions, acetylcholine and the receptors are all muscarinic cholinergic. What happens with acetylcholine binds with muscarinic cholinergic receptor on the heart? Heart rate goes down. That makes your blood pressure go down. You're not in fight, you're at home, okay? Now what happens to your bronchioles? Are they gonna bronchodilate? Do you need them all the maximal air possible? Or are you gonna bronchoconstrict to normal, relaxed size? You're gonna bronchoconstrict a little. Do not need all this oxygen in the air to fuel muscles to get stable. What's happening to rest and digest system? What's happening to all things down? Goes up or goes down? Goes up. It's called rest and digest. Acetylcholine with all your digestive functions to increase, which is a good time to digest because your life's not in danger. So GI peristalsis, which is smooth muscle movement of things, or into your GI tract increases. GI tract smooth muscle, okay? GI tract glands, lots of glands in your GI tract. They increase their secretion. Your salivary glands, which are GI functions, increase secretion. I will cover, no, I'll talk about that. It's a good time to go potty. So increase the elimination deficit because your life's not at risk. So it's a good time to stop. Whatever you're taking to the bathroom yourself, because it's safe time to do. Okay, that's digest. Epinephrine, your life's in danger. Your brain perceives your life's in danger. Now, it's epinephrine binding to. See it on here? Epinephrine on the right there is known as adrenergic. So the receptor for epinephrine is an adrenergic receptor. So adrenaline is in the receptor's name. I have 2 to 3 receptors, but they're adrenergic. Yes, they're muscarinic receptors. It's for autonomic body functions, but they give them a special name, adrenergic. Now, fight flight, sympathetic nervous system. Now what happens to your heart rate? Epinephrine binds to its adrenergic receptor on the heart. Heart rate skyrockets. That makes your blood pressure skyrocket. Your body's delivering oxygen and glucose at a faster speed to fuel your escape. Now what's happening to the smooth muscles of bronchioles? Are they going to bronchodilate or bronchoconstrict? If they dilate, they'll allow more air in. They bronchodilate. You get all possible air, oxygen into your body. You can get that oxygen to your muscles and other things that need it to speak. Now, fight flight. This is a good time to sit back and digest. No. Your body's going to shut all GI activity down. That's not going to save you. Okay? All peristalsis slows down. Glandular secretion stops. That's why when you're scared, you feel dry mouth because the salivary gland stops releasing. All right? The other thing that will happen is arteries feeding your GI tract will clamp down or vasoconstrict. Your body doesn't want to waste available glucose and oxygen on an organ system that's not going to save you. It'll shut it down, but they reduce it. It's not going to save you. Your body's going to divert that blood to the brain, the heart, and the skeletal muscles. Those are going to save you. The blood supply to the gut goes down. Is it a good time when your life's in danger? Stop and go potty. You know, your body wants to shut down your elimination deficit. Someone asked one time, well, why is it sometimes when people are scared, they see themselves? Okay? It's because of the increased blood pressure throughout the whole body and increased muscle tension in your abdominal cavity that puts more pressure on the bladder that makes the sphincter. You can't handle all that tension, okay? But fight, flight. Think of what your body does to save yourself. That's what you got to remember. Then you work back and say, well, what kind of adrenergic receptor does it work like? All right. So first you think, what does the body do that makes sense? Then go back and tie that body with a receptor. Okay. So epinephrine in your peripheral nervous system is that fight, flight response that you feel. Epinephrine. All right. So heart rate goes up, respiratory rate goes up, blood pressure goes up, GI tract activity shuts down. All right, and I'll have all this written down. I have a flow diagram for it. Norepinephrine in your brain increases the rate at which things happening in your brain. In fight, flight scenarios, people feel like the world around them is slowing down. They're like, ooh, right? You don't have that control, all right? Your brain is working faster, which makes things around you seem to be going slower, speeding things up, because that might save your life. So I have a table, but it's not in the textbook, but I put it in the PowerPoint. So 3 receptors. This is the first one. So alpha adrenergic. Alpha. Come on, Pen. There we go. When you think of alpha, think apple. Okay? What do you do with an apple? You bite it, you eat it, you digest it. Alpha adrenergic receptors are for digestive function, but under fight flight. Okay, so let's see, do I have a picture of an apple? There's the apple. Okay, so think of what happens in GI function. You have decreased GI peristalsis. And that's the smooth muscle that moves things along in your GI tract, including your stomach, sphincters and whatnot. Decrease GI gland secretion. If it's not going to save you, shut it down. Okay? It also controls GI artery vasoconstriction. And I'll put in parentheses, don't waste blood on an organ system that can't save you. Don't waste the blood. GI can't save you. Your body does that. It's going to shunt blood away from things that aren't going to save you. It's going to shunt blood towards things that are going to save you. Body's smart that way. And it happens like that. All right. Okay. So alpha, think apple. You digest an apple. It's for digestive functions under fight, flight. And the response of the GI tract, shut it all down. Ain't going to save you. Now, beta. Beta adrenergic receptors. I'm going to teach you 2. There's more than that. I think there's 4. Might be 5. I don't know. I'm just going to teach you 2. All right. So, beta 1 adrenergic receptors. How many hearts do you have? 1, beta 1. All right. Beta, 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 beat, 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 beat. All right. 1 heart. Beta 1 adrenergic receptor is for your heart. And I'll put pacemaker. For increased heart rate. I'll just put HR. You increase your heart rate because you're speeding the rate at which oxygen and glucose are getting around to the systems that are going to save you. Your body's shunting it that way. All right, so beta 1, 1 heart is for the heart. Beta 2. How many lungs do you have? 2. All right, you got 2 lungs with many different loads. Okay, the beta 2 adrenergic receptor will handle 2 things. I'm going to move this out of the way. It's not blocking. Okay, beta 2 adrenergic receptor is for bronchodilation. Okay, you're getting all the maximal airflow into your lungs so you can get that oxygen to your blood. And that oxygen is going to allow all your cells that are going to save you to do their work. So bronchodilation, you've got 2 lungs. Now, I've got a picture of arteries here and a person running. Running is skeletal muscles, and skeletal muscles are going to save you because it's called fight. You might fight, or you might run. Flight, that's skeletal muscle. So beta-2 adrenergic receptor is also for skeletal muscle. Artery, the arteries going to your skeletal muscles. Vasodilation. Increase blood flow to your skeletal muscles. They're going to save you. They need all the available oxygen and glucose to keep going. Okay, so you think of this right here. Think the artery vasodilation is best to get away. Notice what I did here? Best to be to, best to. It works because when you're eventually at an exam where you have this, or you're at an NCLEX test or something, you're a pharmacology test. Oh my God, there's so many receptors. Okay, is it nicotinic? Is it beta-1 adrenergic? So is it a nicotinic cholinergic, or is it a beta-1 adrenergic, beta-2 adrenergic, or is it an alpha adrenergic? Okay, stop, think. Nicotinic cholinergic, nicotine. Cigarette contains nicotine. You must voluntarily pick it up. Oh, that's not a sympathetic function because it's for voluntary action. Involuntary action under sympathetic is adrenergic. The alpha is for GI because you eat an apple and digest it. The beta-1 is for one heart, beta-1. Beta-2 for lungs and artery vasodilation to your skeletal muscles because it's best to be 2. If you remember those little tricks, you won't forget. You can then dissect the part and choose the right answer because you tied something to it that you'll remember it. This is the key to studying and being a successful nursing student, is because they're going to have so much information and it becomes a blur, and recall becomes hard unless you tied an association to it. And then all of a sudden, it becomes a little easier. So it took me a while to work out these, but they're pretty good. You can come up with your own, but these are the ones I came up with, and it does help. How we doing? Okay. So here's a table that shows the same thing. Adrenergic effects on different organs in fight-flight. So this is fight-flight. Keep in mind, it's fight-flight and what makes sense to happen in fight-flight. Okay? If it's fight-flight, your heart rate's going to skyrocket, and that's going to be beta-1 adrenergic, one heart, beta-1. Your GI tract muscle, smooth muscle, it's going to shut down. Okay? Arteries to the blood supply to the GI constricts because chunks of blood away from the GI tract is not going to help. Smooth muscle, I'll just put it real simple, decrease GI activity. Now, when they say smooth muscle contraction, that gets, I don't want you to get confused by that. The sphincters close, all right? The sphincter allowing the esophagus to dump food into your stomach, and the sphincter allowing stomach contents to go into your small intestine. They shut, clamp it down, all right? That's what they mean by that, but it's shutting down GI activity. Now, skeletal muscles, the arteries dilate. They vasodilate. You want as much blood going to your skeletal muscles because it's best to get away, beta-2. Your lungs, your bronchioles dilate because you have 2 lungs, beta-2. And down here, stomach and intestine, contraction of sphincters, clamp down to prevent entry of stuff, all alpha, all apple, okay? So that's your body's autonomic response to fight-flight. It's ruled by epinephrine, known as adrenaline. It works by adrenergic receptors, and I gave you 3. There's more, but I just gave you 3. Now, I'm going to have nursing application. I've got a clinical app online, which you can look at. It's being hidden by this, all right? But you could treat people with a beta-1 agonist. And it's good to increase heart rate and cardiac output. That's how much blood leaves the heart, goes into the aorta. For heart failure patients, the heart's not an effective pump anymore, and so you kind of want to get it to pump better. And so you give them a beta-1 agonist. And that beta-1 agonist is called dobutamine. Okay, and I'll put up here, makes the heart beat faster. Because that's how I remember it. Dobutamine makes the heart beat faster. I know, lame, but I always remember it, all right? And that's good if you want to increase the heart's output, all right? And that's a reason that you might give it to someone. It it stimulates the pacemaker receptors directly. Okay. It doesn't increase epinephrine. It's stimulating the receptor. We're going to have a lab called the PACE lab, which is, I think, next week. And we're going to give you a T. I'm going to give you a T that will act as an agonist to some of your PACE receptors and a blocker to others. And it's going to bring home and this is just an herbal tea. It's going to bring home how effective a pharmacological drug is as an agonist or a blocker. All right. Okay. You can give someone a beta-1 and beta-2 agonist. It will increase heart rate and cause bronchodilation. All right. You might have a situation where you have a patient that needs both of those things. And so that's going to be isoproteronol. Now, I have not come up with a cool way to remember that. So if you come up with something, let me know. Help a sister out. Okay. But that will do both of those receptors, stimulate them directly. So I think I have 3 agonists and 2 blockers. So the next one is going to be a different kind of agonist. It's going to be, just a beta-2 agonist. Oh, yeah. I know what this one is. There's several drugs. I'll pick the most popular one. Albuterol. Have you heard of albuterol? Isn't that the inhalant that you give to people who have asthma? And they breathe it in, and it's a beta-2 agonist. It causes bronchodilation. People who are having an asthmatic attack, it's called a rescue inhaler. That's what it is. And it's only meant for emergencies. But if this person who has asthma is having an asthmatic crisis, their bronchioles constrict. And I've had this happen. I'm not an asthmatic, but I had an allergic reaction to horse saliva. I was out on a field call, and the vet was there, and I was holding the horse steady while he floats the teeth of files. You got to file them down because they get long in the tooth. The horse was very friendly, and it kept licking me. I was like, oh, you're such a cute guy. Got back in the truck, we're heading home, and I'm starting to get rashes all over my body. Could be from the saliva, but then I started having respiratory problems. My bronchioles were constricting because an allergen my body did not like was causing a histamine reaction, and my bronchioles shut down. They didn't shut down completely, but I was wheezing. Vet takes me to urgent care. They test me and say, yep, your bronchioles have constricted. They gave me epinephrine, and they sent me home with a rescue inhaler. Okay. Now, so you're having this asthmatic attack or whatever it is, you take the inhaler and you're delivering a beta-2 agonist that causes your bronchioles to relax and open up wide. Now, while I'm here, I want to do a teachable moment. How many people, you're going to see asthmatics or other people with respiratory problems. If you are taking the patient history and they say, what drugs, what medications are you on? Okay. And you're filling out on the computer, it's all on the computer. And you say, well, I have albuterol. And you're like, just albuterol? You don't have anything else you're taking for your asthma? Nope, just albuterol. We need to talk, because that's going to become a problem if it isn't already. So my husband was asthmatic. He's being treated correctly now, so he doesn't have problems. But if you only use a rescue inhaler, it's only meant for emergency. Your body would become tolerant to albuterol, and you get to the point where your bronchioles won't respond to it anymore. This is exactly what happened to my husband. He'd be waking up in the middle of the night with an asthmatic crisis, taking the albuterol, and it wasn't working anymore. And that's what will happen. Your body tolerates it. So what should happen if you get this patient history, you got to make sure and let physicians, assistants know, whoever, they need to be taking anti-inflammatories to keep the inflammation process down, so you don't get to an asthmatic crisis event. And now they have things that block eosinophils, which are involved in, I don't write any of this down, but I see the commercials for it, anti-inflammatories and things that block the white blood cell contributor to asthma. A couple ways of going. And as long as you're keeping the histamine reaction down, the inflammatory reaction down, you'll have less and less crisis events, and you won't have to use the albuterol or terbutaline or whatever. There's many formulations. You won't have to use it as frequently, so you won't build a tolerance. So when you're in an emergency, it works. All right, that's really important. All right, blockers. We'll start with a beta-1 and beta-2 blocker. It blocks both the beta-1 receptor on your heart and the beta-2 receptors for epinephrine on your bronchioles. So what will happen is, if you have hypertension, right, one of the big 3, chronic hypertension has got to be treated because it causes huge problems, which we'll discuss in the cardiovascular chapter. But you got to get that blood pressure down. You're going to have problems. Your patient will stroke out over time, all kinds of things. So you got to get the blood pressure down. There's many different ways to treat high blood pressure, many different drugs coming from many different angles. This one is block the beta-1 receptor on your heart, so epinephrine can't make your heart rate go up. Your heart rate goes down, your blood pressure goes down. One happens after the other. The thing is, it'll also block the beta-2 receptors on your bronchioles, so they might constrict. If you have a patient who has high blood pressure and no respiratory problems at all, this drug is going to be fine. It's one of the first of its kind developed, probably on the cheaper side by now, but it's called Propranolol. Okay, so you get decreased heart rate and blood pressure goes down, but you have bronchoconstriction. It's not for people who have respiratory problems. If they have asthma, COPD, COVID, anything else that can depress the respiratory function, this is not the drug for them. You'll bring their blood pressure down, but you'll send them into a respiratory crisis. No bueno, okay? That's not the drug for them. Patient history, which you guys are taking, is very important. Because they might not think it a big deal to mention that. Well, I'm in here for a high blood pressure problem. What does it matter about my asthma? It kind of does matter, because it changes the drug that's best for you. When you look at a drug or package of any kind, package insert, it says contraindication. Don't give this or take this drug if you have this. This is a case of that, contraindicated in the case of people with any kind of respiratory problem. What they need is this, the beta-1 specific blocker, which is called Atenolol. Okay, it blocks just the beta-1 specific receptor on the heart. It's not going to touch lung function. So decreases heart rate and blood pressure, doesn't affect the bronchioles. It's good for hypertension, people with hypertension that might have a respiratory problem. So decrease heart rate, but don't touch the lung function, okay? Now that's the simplest. I know that if you don't dose atenolol correctly, it can actually go after the beta-2 receptors, but that's too much information. Learn that in pharmacology. You must dose drugs correctly for the patient's body weight. But that, when I think of atenolol, I think attenuation. Vaccines are attenuated. They're made specific to a particular strain of a virus. We probably now know this better than other generations because of COVID. All right. Every year you get a flu vaccine. It's not the same flu vaccine that was given last year. You know why? The flu has mutated and it's changed. And so they create a new vaccine every year that has been attenuated or made specific to a particular strain. So atenolol has been attenuated. That's what I think of, to a specific receptor and not another. All right. So these are very common drugs. So what are these? Okay. You see it on the regular every day. I know students from previous semesters that had a problem with regulating the blood pressure. The blood pressure is a little high. They had a little tachycardia. Means their heart rate was higher than normal. And they're on beta blockers. You know, it's not something just for old people, because people can have high blood pressure at your age, especially if it's hereditary. All right, so these are very common drugs. They work by these receptors, and these receptors work with epinephrine in fight-flight responses. So I've taken all this pathway and I've tied it to some common pharmacological drugs that you are going to see. Okay, now, before I get too far, I'm going to escape out of that. I'm going to come back, keep up to where we are. Oops, too far. Okay, I'm going to go to my web page. And I'm going to show you ways to study the acetylcholine pathway and the epinephrine pathway, because it's not on the PowerPoint. So I'm going to show you where it is. So scrolling down, it's going to be, okay, I don't know if I have it. Okay, now I have in this chapter the acetylcholine signaling flow chart. Okay, that might not be complete. It's this, and this, all of this. Okay. And then, of course, I have the key, but also on that pathway, but I don't have the key for it on that particular location on the web page. I'm going to show you where I have the complete total, both pathways. If you go down to chapter 4, part 3, CNS, where are my, there it is. Here's the full pathway. You're ignoring this. but acetylcholine, voluntary muscle responses, acetylcholine, nicotinic cholinergic receptors. If you look at the key, you'll see that. Involuntary motor responses to acetylcholine and epinephrine. I've got two pathways here. On the left is acetylcholine, all right? All work by acetylcholine binding to muscarinic cholinergic receptors. And you fill this in, what makes sense? Ignore the nerves, we haven't covered that yet. What makes sense under rest and digest for your heart to do? Goes down. Blood pressure goes down. If it's rest and digest, are your bronchioles dilated for maximal airflow because you need it? Or are they constricted down a little? Yeah. Question? Oh, you said constricted? Okay, sorry, math. Okay, all things GI. Go up or go down and rest and digest? Go up, because it's a good time to digest. Urination, defecation, increase or decrease? Increase because it's rest and digest. What we just covered now is the opposite. Sympathetic is epinephrine, is a beta-1, beta-2, and alpha adrenergic receptor. It's fight, flight. Your heart rate now skyrockets, which makes your blood pressure skyrocket. Now your bronchioles do what? Dilate or constrict? Dilate. You need all that air. All things GI. Shut it down. It ain't going to save you. Okay? Blood supply to the GI tract is constrict. Now, skeletal muscle arteries, they will dilate because you need all that blood flow to fight or flight. Urinate, defecate, increase or decrease in fight, flight. Shut it down. Ain't going to save you. Okay? Now, if I said, what is the adrenergic receptor on the heart? We've got three choices: alpha, beta 1, beta 2. The heart. Beta 1, one heart. Your bronchioles, beta 1 or beta 2. Two lungs, beta 2. GI tract, what kind of adrenergic receptor? Alpha, because alpha, you digest an apple. What about arteries going to the GI? I'm sorry, to the skeletal muscle. Sorry. Arteries going to the skeletal muscles. Do they dilate or constrict again? They dilate. What is the adrenergic receptor that's best to get away? Beta 2. Right? It'll take some studying, but hopefully that's presented in a way to you that when you study, you're like, I get it now. I get it now. Okay? All right. So, checking on my time. Got a little bit of time. I took time going over this because I really want you to understand it. I want to make sure and present it to you in a way that I think is more palatable and understandable. Because you do need to know this in pharmacology. Semester 1 in nursing, you need to know it. So, now, we've got four more. Might not get to all of it today. I'll wrap it up on Wednesday, and on Wednesday, I'm going to start chapter 4, part 2. But here are other amino acid-based neurotransmitters, but they're different amino acids than for epinephrine, dopamine, and serotonin. Glutamate, glycine, and GABA. I'm going to write some quick stuff down, and then on Wednesday, I'm going to go into more detail. Glutamate is in the brain. Oh, sorry about the red. In the brain, it's always stimulatory. I would say always stimulates. Okay, it's a stimulatory neurotransmitter. There's two neurotransmitters in the brain that are always stimulatory. Acetylcholine is and glutamate is. Glycine is inhibitory, and it's in the spinal cord. So when I think of glycine, I think serine, which means calm, in the spinal cord. And I will explain what that does on Wednesday. GABA is inhibitory in the brain. So I think of B and GABA, I think brain. All right. Hey, quick review. I talked about a treatment for cholinergic syndrome that will stop the muscle seizures in cholinergic syndrome by stimulating GABA. GABA inhibits from the brain, inhibitory in the brain. So it calms the brain and inhibits skeletal muscles. Calms your skeletal muscles down. Okay? When you're in deep sleep, GABA keeps your skeletal muscles paralyzed so you don't get up and walk around when you're in deep sleep. Now, you remember the drugs? I'll give you 3 drugs, A, B, C. Atropine, Tupam, or Valium. Which one of those drugs stimulates GABA and inhibits skeletal muscles and will stop seizures in cholinergic syndrome. Valium, benzodiazepine, calms your skeletal muscles by stimulating GABA, which calms your skeletal muscles. We come back full circle to that. All right. It's a great place to stop for today because I know I threw a lot at you. But we'll finish up these and one more neurotransmitter on Wednesday. We'll start a different part of the chapter. I'll see some of you in lab. Don't forget to the quiz. All right.